Good evening. This is Dr. Bill White again and the American Orthodontic Society, and I want to talk to you a little bit about tooth movement. It's complicated if you really get down into it, what happens in tooth movement. So I wanted you to kind of catch on to what we do here. This young man, and I'll go ahead and let's get started. He's a neat kid, he's got a good facial structure, facial height, and all these good things are okay, except he's got an extremely crowded anterior portion of the mouth and the upper portion especially, not the lower portion. And so I didn't want to take any teeth out on this young man, so we're going to try to save everything we can. And we've got, you look at the models, he's not a mouth breather to any extent anyway. The upper arch is overlapping the lower arch, except with one spot right up here around this lateral, which isn't a very difficult thing to deal with there, pretty easy. So we'll correct that lateral and get it out into space, the proper space for itself. Now let's go ahead and look at the other deals. You can see the lateral is really pulled back. There's a permanent lateral caught behind the lower permanent lateral too. Over on the left side of the mouth, everything looks pretty good there. When we look at the upper arch just down on it, the deciduous cuspids are gone here, and the lateral on the left side is pretty well in position, and the one on the right is the one that's in the crossbite. From there, on the lower arch, everything looks pretty good. They've already got the bicuspid in right here, and this is a deciduous cuspid. This one looks like it's about ready to go there, and so that's all pretty normal. Nothing big deal about that. All right, here's your upper again, just showing that lateral how it's pushed back lingually by the lower lateral, and this was our office. I just come in part-time and work there. That was after I was 75 years old. I went and worked with Dr. Hurley and stayed with him for 12 years after that. So here's our young man a little later on, and we're looking at it, and everything looks good. And so we have started to do this, and I want to come in and show you the tooth movement that we're doing right here. Now this upper cuspid is back into place up here, and it's coming over here toward this lateral, and we'll see that on the x-ray. And so we're trying to expand this space between the bicuspid and the lateral right here to get that cuspid into position. Now, what we've done, let me see if I can just get a white sheet of paper here. We have an arch wire going along like this, and we have a lateral tooth sitting in here somewhere, and then there was a bicuspid back in this area, something like this. And what we wanted to make some room up here to get this cuspid down, so we put a forward tip in that line. Now that will tend to make this root go in this direction, and we put a distal tip. In other words, we came down and came up, came across this way, and this one, and it tends to make this root go this way, and we'll try to get the cuspid tooth down in that space. And then we got spring in between here, pushing the teeth apart. And you have to think about a lot of different things. I mean, if you just take a tooth out here, I'll just draw a line and push on it, it will, you would think, rotate at the tip down here. But if the tip of it is in cortical bone down here, then that makes a difference. The hard bone right catches that right there, and the tip of it will go back in this direction, and the crown portion will go in the other direction. So your root goes opposite from what you want. Now let's see that in action over here. And also we've got a deep bite. So we've fixed this intruding arch, which go back and study some of those deals on intruding arches. This arch comes out, drops down, makes it like that, and then it would go down and come up like here, and we raise it up and hook it on these teeth. As it brings these teeth down, you have to piggyback it over this normal archway that we've got going through here. As it brings the teeth down, the same force that goes down this way is pushing up on the molars in this part. It'll be divided by the two molars, and it tends to elevate the molar on both sides. Now as it pushes this down, you hook this up, and these teeth start going down, and that tooth starts, it's kind of cocked up. I can't draw it on that sheet. Let me end that, and I'll go to another sheet here and show you what happens there. Like you've got a molar sitting over here, and we've got this. I'm just going to leave the other archway out. We've got a little deal on here, and we come out of here, and we drop this and circle it, and then we come down around and come back up and drop it, circle it, and go into this molar over on the other side of the mouth. Now, if I raise this up, but it wants to go down, see, and I'm going to pick it up and hook it to these teeth over here. Now, as I pick it up, that's going to tend to rear this tooth up in this direction, see. And the reason this works is the same thing that works that thing they stick on here and for class 2 malocclusion and all that kind of stuff, is the occlusion. Now up above, if the tooth is fitting right, the upper tooth comes right in here, and if it's class 1, say, and this tooth raises up a little bit, and that increases the contact right in here on both teeth. And the occlusion is a force, and we have to deal with all these forces that are moving these teeth around in different ways. So we're on the side of the tooth, and it tends to rotate a little bit, but that doesn't stop it. Now this arch will be out, it'll be something like this up here. Now it's going down, and these teeth are harder to intrude than it is to extrude a tooth. So you'd think these 6-year molars would move all over the place. But the occlusion keeps those teeth down. And that's why this little gadget you stick on the teeth, you go out here and you hook your class 2 elastics to, or you go up here and look at class 2 and start these early class 2s, because the occlusion keeps those 6-year motors in place, and they will be reared up a little bit. Now, I have a beautiful case that I did years ago where I just put these 2 little wires in when this young man, and he ran off on some commune or something and didn't come in for 6 months. And he just had those 2 little wires, and he had a deep bite when he started. We put that on, and when he came in, he couldn't get his front teeth together. And his 6-year molars hardly looked changed in there. So there's a lot to understand about intruding arches, so I didn't want to get off too far into that. I wanted to get in here. You see this wire going down like that, then it's straight across, and then over here we've got a little bit of that same thing, but not as much, because this cuspid came in all right, or better than the other one. But this is up like this, goes over, and now goes down and up again. And so it's taking this root and pushing it away in this direction. And that's the way the bend in the archway is. Now we've got a spring in here, and the spring pushes the crown in the other direction. I mean, it pushes it out here, and that would tend to bring this back, you see. But this tip in the arch wire overpowers this spring, and there's a gap in here will open up, and that's the way we open up to put an implant or bridge or anything like that. So you need to understand that type of movement of the teeth, just the tipping of teeth, and what kind of bone the tip of the tooth is in. If it's in cortical bone, or part of it in the cortical bone and part in the cancellous bone, the tooth will move and the cortical bone won't move much in there. Now, if you've got somebody with a lot of periodontal bone loss and you just have a small amount on there, it will tip more at the point than it will if you've got a lot of cortical bone. It'll tip further up on the tooth. You just have to kind of think these things out. Now let's look at what happens in here. And we have another force that we'll deal with. And we've got a whole bunch of them in here that we're dealing with, but I want to show we do a palatal separator here to get some space here to open this up. So you see this spring is pushing the crowns apart, and the tip is pushing the roots apart at the same time. Otherwise, if we just put the spring in, the crowns would move like this and the roots would come together. So we need the space where the roots are, as you'll see in just a minute here. Now, this is another view of the intruding arch and how it's intruding those anterior teeth or leveling this bite out. And there it's level of some, but not that much. Now we also had an expanding archway. You see this loop back here, and with that loop probably was something like that. We put it in and pushed it back, so the whole archway is tending to bring everything to the front at the same time. See, so you've got forces in here, all kinds of them, and then if you have a person that's coming along and they're breathing through their mouth, or they're sucking their thumb, or they're doing something else, you have all kinds of forces. Or they got something having a biting their nails, or just all kinds of things can have an effect on the teeth. How they sleep at night with their head like that has an effect on it also. Okay, let's go on to another. Now there the spring is kind of giving way to this. You see, this tooth is kind of angling back this way, and then going that way. We're opening up. You see our arch wires pushing this out, and we're making space in there to bring that through. But even that wasn't enough, so we come back and put a palatal separator. This is just a picture of the models. I don't need to show that. Now we've been through all that. But here is the cephalometric. In other words, I didn't want to extract teeth on this young man. I wanted to expand the arch and bring the teeth in there. So here is another situation of tooth pressure. Now, we've not talked about it much, but you look at this little circle that is around that cuspid now. That's the follicular cyst, more or less, on that cuspid. It's a cyst that breaks free down in here. Now, this one has some growth. And you have to think about that tooth as if it were you had your fist in a balloon, and the balloon's full of water, and you've got your balloon, your hand in water. It just stays like that. But if you push up against something, it will flatten on this side and the other side, which is doing here. As it runs into teeth, it kind of flattens out in that area. Now, if you come in and eliminate or spread this thing out, the circle will round back out again. And this follicle comes through, and as the tooth breaks through, that becomes the epithelial tissue around the neck of the cuspid. All right, let's look at what happens here. Now we come in and we take some teeth out, some baby teeth down here, and remove those baby teeth. And we've got the permanent tooth here. Now here is what we're doing. This one wasn't as bad, but you see we've got a line like that bringing this root over this way where it was here. It'll move over, and we'll get the cuspid coming down in that gap. And here you see that arch wire like that coming over, and do it like this over here. So we're pushing this one back here, this lateral especially, over in this direction. But still, there's not enough room to get this cuspid in. So we have to go back and come up with something else. It's a little, add some more space in there. So there it is like that. When they came in at this time, we realized we had to put a palatal separator. We were not getting where we wanted to go. So we put a palatal separator in, and the force in the palatal separator is back in the back. It's not too much up here in the front. So we learned that later on for older people, we want something in the front tooth to give a better pull on it. So let's see what we do here. Okay, here's the palatal separator in. It's opened up some space to bring the, to get this cuspid off of that lateral and get it to come down into that space. So there's a lot of understanding that you need to know about the separation of the sutures up here in the palate, bringing the centrals and the laterals together in that space, and having the space that you created in the spot you wanted it to be. And so you go through that. Now this, as we get that wider, and you see the space is better, and now this follicle is pushing that crown in that direction. So it's headed down here. Now this one, we pretty well got it made over on the, I guess it's the left side. And the right. Now, let's see. come into this is the I forget, this is number 6 Panrex. So, and you see how we tilted that root over and pulled this one not so much, but a lot of tips. You see that tip in that arch wire? That put that root in that direction. And then got a cuspid around it. And now this follicle apparently has broken to the outside, and the thing has gotten smaller. You see, it's not as big as it was. This cuspid is in place on the other side of the mouth. Now the cuspid's coming through down here, completely rotated, and that's just something we, regular orthodontics, I'm not going to get into that now. So here we can come in now and expand that wire a little bit and then squeeze that cuspid right into place. We have to close some spacing in between here. I don't show this to the end, but there was something back here. This is a wisdom tooth coming in. That doesn't have anything to do with this, but here was a good picture of the tip that we put in that tooth. And here's the cuspid coming down in this area, and this tip is tending to bring a lateral roots over here, and also to bring a central root that way, so we can group these roots and move them where we want to by learning how to put tip and torque into these arch wires that we put in there. You can make the tooth do just most anything you want it to do. So here's our young man now, and this is the far as I go with it. We went ahead and finished the case out, and here he is a little older. And I appreciate you watching this, and maybe you picked up something from it. I hope you did, but understanding how teeth move involves so many things. A cortical plate, a bone, the cancellous bone, the periodontal condition of the amount of bone that's on the tooth makes a difference in how it moves. And whether you move the whole tooth as a body or you tip the tooth, makes a difference where your root is. So movement of teeth is something you fully need to understand, and you can make it do what you want to with arch wires and brackets and things. So I'm going to close out and say good night. It's pretty late at night here, and I hope you get something from this.